Ankle-foot joint complex, foundations for evaluation, differential diagnosis, and prognosis. As always, the objectives and student outcomes, students will learn foundations for evaluation, differential diagnosis, and prognosis of the ankle-foot joint complex, and how those foundations develop through performance and application that increases from basic recall to complex evaluation and creation. So we're going to start out by talking about the characteristics and articulations of the ankle-foot joint complex. You have the distal tibiofibular joint. That's the articulation of the tibia and the fibula. You have the talocrural joint, the articulation between the tib fib and the talus. You have the subtalar joint, the articulation between the talus and calcaneus. You have the metatarsal joint, the articulation between the talus and the navicular, and also other osseous structures. And the forefoot. Forefoot starts with the articulation of the metatarsals and your cuneiform bones, as well as your cuboid. So we're going to go back and make sure that we review those in this presentation, and also make sure you review those on Charlie and lab. The tibiofibular joint. This is the distal tibiofibular joint that we're talking about, and the distal tibiofibular joint is a fibrous union between the lateral aspect of the distal tibia and the distal fibula. As you can see right here, you see the anterior inferior tibiofibular ligament, which joins, we know that ligaments joins bone to bone, and so you got fibrous connective tissue of the anterior inferior tibiofibular ligament joining these two structures along with the interosseous membrane. So when we talk about that fibrous union of the tibia and fibula, we're talking about the interosseous membrane and also the anterior inferior tibiofibular ligament joining those two bones. Now we're going to talk about the talocrural joint. So now what do we get with that talocrural joint? So the talocrural joint, we know, is the articulation among the tibia, talus, and fibula. It's considered a synovial hinge joint with 1 degree of freedom, right? So typically at the talocrural joint, we have plantar flexion, dorsiflexion movements. There's significant stability in dorsiflexion. However, plantar flexion, there's more mobility with plantar flexion. Typically, we get greater ranges of motion with plantar flexion than we do with dorsiflexion. With plantar flexion, the normal range of motion typically is about 0 to 50 degrees, whereas with dorsiflexion, the normal range of motion typically about 0 to 20 degrees. So you have more degrees and more mobility with plantar flexion than we do with dorsiflexion. Also, with dorsiflexion, we have a more dense or greater resistance with dorsiflexion due to the thickness of the Achilles tendon. So you got a structure that is going to provide greater resistance to dorsiflexion than your structures that resist plantar flexion as well. Your osteokinematic motion at the talocrural joint, as I said earlier, are dorsiflexion and plantar flexion. Your capsular pattern is plantar flexion is greater limited than dorsiflexion. So this is similar to your knee flexion capsular pattern, where knee flexion, you have a greater limitation of knee flexion than extension. Why is that? You have more range of motion with knee flexion. So since you have more range of motion with knee flexion than you have with knee extension, your capsular pattern of restriction, knee flexion is going to be greater restricted because you typically can achieve more range of motion with knee flexion. Same thing at the talocrural joint. Typically you're going to have a greater restriction with plantar flexion than dorsiflexion if there is a capsular pattern of restriction, because typically you can achieve more plantar flexion than you could with dorsiflexion. Therefore, plantar flexion is going to be greater restricted if there's a capsular pattern of restriction. These are just some visuals of dorsiflexion and plantar flexion. Plantar flexion is typically referred to if we're just using the terms flexion and extension. Sometimes someone may say ankle flexion. Dorsiflexion is typically referred to as ankle extension. So if you utilizing the term ankle extension, that is actually saying ankle dorsiflexion. If someone says ankle flexion, they're talking about ankle plantar flexion. So still at the talocrural joint, talking about the loose pack and closed pack positions. So the loose pack position for the talocrural joint is 10 degrees of plantar flexion, midway between the maximum of inversion and eversion. So I'm going to say more so like a neutral foot or neutral subtalar joint with 10 degrees of plantar flexion. And the closed pack position is maximum dorsiflexion. And again, the closed pack position, we're talking about when things are most congruent, when they are close in proximity to each other. It's a closed pack position, or intimately articulated. And so here's an example of our loose pack position right here in this slide right here on this side. And here's an example of the closed pack position with the foot being maxillary dorsiflex in the closed pack position or closed chain position, with it being demonstrated in the closed chain position. All right. Now we talk about the subtalar joint. So earlier I indicated that the subtalar joint is the articulation between the talus and calcaneus. All right. Now we have different ways in which one can move on the other. So typically in an open chain position, the talus is moving on the calcaneus in the open chain position. In the closed chain position, typically the calcaneus is moving on the talus. So almost like our knee. So remember I talked about the knee joint in an open position, open pack position, the tibia is moving on the femur. And in the closed chain position, the femur is moving on the tibia at the knee. So sort of the similar concept at the subtalar joint. So again, in an open pack position or open chain position, typically the talus is moving on the calcaneus. And in the closed chain position, typically the calcaneus is moving on the talus. There are three articulations. You have the anterior, middle, and posterior areas between the talus and calcaneus, which permits 1 degree of freedom. We're talking about inversion, subtalar inversion, eversion, or some say subtalar pronation, supination. On the anterior and middle articulation, there are 2 convex facets on the talus and 2 concave facets on the calcaneus. In the posterior aspect, there is a concave facet on the inferior talus and a convex facet on the body of the calcaneus. So here's some images right here. Again, your osteokinematic motions at the subtalar joint are inversion and eversion. More so, we get more range of motion, typically a little bit more range of motion and freedom with subtalar inversion than eversion. Most textbooks will say they are, most textbooks will read eversion, subtalar eversion being about 0 to 5 degrees, and some will read inversion. This is at the subtalar joint. Inversion 0 to 5 degrees or maybe 10 degrees. So just depending on the text. The capsular pattern of restriction, there's going to be a limitation of various range of movement. Okay, so when we talk about various range of movement, what are they talking about? We're talking about inversion. Inversion. So eversion is a valgus range of movement. It's going to, eversion is synonymous with subtalar pronation. So there's going to be a valgus range of movement with eversion / pronation. With inversion and supination used interchangeably, there's going to be a limitation of various range of movement with inversion and supination. So again, we typically get more inversion and supination with active range of motion than we do with eversion. So therefore, you get a limitation of various range of movement with a capsular pattern of restriction. So now you see your motions of inversion and eversion. And now we're talking about loose pack position and closed pack position of the subtalar joint. So the loose pack position is midway between the extremes of the range of motion. So we're talking about midway between inversion and eversion. Your closed pack position is supination. A supinated rear foot is typically referred to as a stiff foot, a hypomobile foot. A pronated foot is typically referred to as a flexible foot or unstable. Supinated rear foot, if a patient comes to you with a supinated rear foot, if you look at their shoes, how's the wear gonna look on their shoes? So the posterior lateral aspect, so towards the back. So say this is me, this is my foot, you all see my foot. So if I have a supinated stiff foot, then this part of my shoe is gonna wear down like so. And the person's shoe is gonna probably end up looking like this underneath. So you're gonna get some patients who come in like that. And if you look at their shoe wear is gonna tell you the positioning of their foot, especially their rear foot. Now you're gonna have some people who their shoe is gonna wear down on the inside of the back of the shoe. What kind of foot is that gonna be most likely? Say again? Pronated. So most likely therefore their rear foot is gonna be fixed in a pronated position or excessively pronated, because the inside of the back of the shoe is gonna be worn down. Okay. So again, loose pack, subtalar joint, neutral between the extremes of inversion and eversion, and the closed pack position is the foot being supinated, which is a stiff, rigid foot. We don't want that, especially if we walk a lot, we run a lot. That's not good, because it's gonna work its way up the kinetic chain, and the hip, the tibia, and femur are really not gonna be doing what they typically supposed to do, especially during initial contact and load and responsive gait, and it's gonna throw things out of whack. All right. Here we go, mid-tarsal joint. So make sure you know what the mid-tarsal joint consists of. So the mid-tarsal joint, again, is the talocalcano-navicular joint and the calcano-cuboid joint. And so I did indicate earlier talus and navicular, but also the articulation between the calcaneus and the cuboid. So you see this red line right here? This red line is your mid-tarsal joint, okay? So you have two axes, a longitudinal, oblique axis, and motions occur about these axes, which are triplanar motions at the mid-tarsal joint. Again, mid-tarsal joint, you do inversion and eversion as your osteokinematic motions. The capsular pattern of restriction is going to be dorsiflexion is going to be greater limited than plantar flexion. Plantar flexion being greater limited than adduction, and adduction being greater limited than medial rotation. And we're talking specifically at the mid-tarsal joints. Mid-tarsal joints is also going to have inversion to occur and eversion to occur at the mid-tarsal joints. So when it comes to compensatory strategies of the rear foot, mid-foot, and forefoot, the mid-foot is going to do the same thing as the rear foot. Up and down the lower extremity kinetic chain. So if I'm excessively rotated, externally rotated at the femur, what's the tibia going to do? Externally rotate. what's the subtalar joint gonna do? So my femur's externally rotated. I'm retroverted. That's gonna work its way down the lower extremity kinetic chain. So my femur is externally rotated. My tibia is wet. Externally rotated. My subtalar joint is wet. My subtalar joint is gonna be supinated, because external rotation is gonna put my subtalar joint into supination. And now, I just told you my mid-tarsal joint is gonna do the same thing as the subtalar joint. So my mid-tarsal joint is gonna be wet, supinated, and then my forefoot is gonna do what? Pronate. I'm introverted at the hip. My hip is introverted. So now I have some internal rotation going on. So down at lower extremity kinetic chain, was my femur internally rotated? What's my tibia gonna do? What's my subtalar joint gonna do? What is my mid-tarsal joint gonna do? What is my forefoot gonna do? There you go. The forefoot. So, Liszt Frank joint, fascinating. A Liszt Frank fracture is fracture of the midfoot. Very fascinating. But anyway, tarsal metatarsal joints, metatarsophalangeal joints, and interphalangeal joints, those are the joints that are in the forefoot. So the forefoot begins with the tarso-metatarsal joints. Okay? So the first metatarsal articulation with the first cuneiform bone, that is the forefoot. So the metatarsal articulation with the cuneiforms and the cuboid make up the tarso-metatarsal joints. Now, you also have your metatarsophalangeal joints. So the metatarsophalangeal joints is when the metatarsal articulates, the heads of the metatarsals articulates with the base of the phalanx, or the proximal phalanx. So each of these articulations of the heads of the metatarsal bones articulated with the base of the proximal phalanx, those are your metatarsophalangeal joints. And then below those, or distal to those, are your interphalangeal joints. So transitioning into osteokinematic and orthokinematic motion at the distal tibiofibular joint. So this, we're talking about the articulation between the distal tibia and the distal fibula. At the distal tibia and fibula, we have a convex fibula moving on the concave portion of the tibia. And therefore, since it's convex moving on concave, the motions are going to be in an opposite direction. Your osteokinematic motion and orthokinematic motions are going to be in the opposite direction. And remember, when we're talking about the movement of the fibula, we're not talking about your typical cardinal planes. So in your textbooks, they're described as a spin. So the lateral spin of the fibula with dorsiflexion, that is what occurs, the lateral spin of the fibula, and therefore you get a proximal glide of the fibula. So when it's a proximal glide of the fibula, what is it talking about? So it's moving superiorly. So when we say proximal, moving superiorly. Distal, moving inferiorly. So with the medial spin of the fibula, which is what occurs with plantar flexion, you have a distal glide of the fibula, meaning the fibula is moving inferiorly. And we're talking about the distal aspect. We're talking about the distal tib field joint. And with pronation, there's what they call a lateral spin of the fibula, where there's a proximal and anterior glide of the fibula. So we have a superior anterior glide of the fibula, whereas with supination, there's deemed no spin, roll, or swing to occur, but however, they're saying that there's a posterior glide of the fibula, inferior and posterior glide of the fibula with supination. So it would be the opposite, supination would be the opposite of pronation. So here's some visuals. So this is a visual of the distal tibio-fibular articulation, and this right here is a picture, a zoom in of the proximal tibio-fibular articulation. Well, we're going to the talocrural joint. So the talocrural joint, we have convex talus moving on the concavity of the tibia and fibula, the mortise joint, which creates a concavity, a concave area. When you combine the tibia and the fibula, you have like a concave tent type of surface. And the talus moves on it in the open chain position. All right. So the osteokinematic motion and orthokinematic motion occurs in the opposite direction because you have convex moving on concave. And this is typically in the open chain position with superior movement of the fibula, which is dorsiflexion. There's a posterior medial glide of the talus. So a posterior glide of the talus / medial glide of the talus. Therefore, dorsiflexion can typically be improved if these accessory motions are limited. If the posterior glide is limited or medial glide is limited, either of those glides of the talus can limit ankle dorsiflexion. The inferior movement of the fibula, that occurs with plantar flexion, there's an anterior lateral glide of the talus that has to occur with plantar flexion. So this is a diagram that shows you one thing that is helpful is to get a vision or visualize these things in your head. And that when you're able to visualize it, you're not relying totally on words. You're not relying totally on memorizing words if you get a visual in your head. So for example, look at this visual of ankle talocrural dorsiflexion. But it's basically showing that the talus is sliding posteriorly with ankle dorsiflexion. Okay, it's showing you which way the talus is sliding. And so we know it's going to be in the opposite direction of the movement. So we have the foot moving anteriorly based on the anatomical position, and the talus sliding posteriorly. Same thing with plantar flexion. We have we have a posterior swing and roll of the foot moving posteriorly based on the anatomical position with an anterior glide or slide of the talus with plantar flexion. So those are orthokinematic motions that have to occur in order for us to achieve these motions. They have to occur. So the talus has to slide posteriorly with ankle dorsiflexion, and with ankle plantar flexion, it has to slide anteriorly. If it doesn't, then we don't get these motions to occur. Okay. All right. Now we're moving on to the subtalar joint. So the subtalar joint is interesting because it has all kind of articulations. All right. So we got a convex and concave anterior and middle talus. So we got a convex anterior and middle talus, and we have a concave anterior and middle calcaneus. So since we have a convex anterior and middle talus and a concave anterior and middle calcaneus, when we have convex moving on concave, the talus moving on the calcaneus, then your osteokinematic motion and orthokinematic motion is going to be in the opposite direction. All right. Now, if you have concave moving on convex, then we know our osteokinematic motion is going to be in the same direction. So typically, at the subtalar joint, when we're in the closed chain position, when our foot is fixed on the ground in a closed chain position, our osteokinematic motion and orthokinematic motion is going to be in the same direction. If we're in an open chain position and I'm sitting on the edge of the table and we're in an open chain position, our osteokinematic motion and orthokinematic motion are going to be in opposite directions due to what is moving on where. okay? So the posterior calcaneus, so going back to the structure, the posterior calcaneus is convex and the posterior talus is concave. All right. So when we are in the closed chain positions, it's going to be the concave portions of the calcaneus moving on the convex portions of the talus when we're in the closed chain position. So I kind of talked about that earlier in the slide, but I'm delving more into it now. All right. So when we talk about the closed chain position, we have the OK and AK motions. So with pronation, we're going to have an outward roll of the calcaneus. So the calcaneus, with pronation, calcaneus is moving outward. Okay? So this is me standing straight forward. This is the calcaneus. Calcaneus is moving, rolling outward with pronation. Typically, what is occurring is a calcaneus lateral arc glide. Okay? The talus is going to move posterior medial. So there's going to be a posterior medial glide of the talus. With supination, in the closed chain position, supination, there's going to be a medial roll. So we know the calcaneus is going to roll medially with supination. This in the closed chain position we're still talking about. That's going to be referred to as a calcaneus medial arc glide. And the talus is going to glide in an anterior lateral direction. All right. Now we're going to open chain position. Open chain osteokinematic motion, orthokinematic motion is going to occur in the opposite direction. So this is me sitting with my leg non-supported, open chain position. My feet are not fixed on the ground. Okay. So now my feet are not fixed on the ground. My talus is now moving on the calcaneus, right? So closed chain, my calcaneus is moving on the talus. So in the opposite direction with the open chain position, with pronation, there's going to be a calcaneal rocking with a calcaneal lateral arc glide. Okay, that's going to result in a medial tilt. So my calcaneus is going to glide laterally, and the tilt is going to create a medial tilt. And then with supination, calcaneal rocking, referred to as calcaneal rocking as well, but what's actually happening with supination, there's going to be a medial arc glide, like so, but then that's going to create a lateral tilt. Okay, so the tilt is going to be on the lateral aspect of the calcaneus. With pronation, the tilt is going to be on the medial aspect of the calcaneus. Now, this is something you have to visualize as well, other than just looking at the wording of it. You have to try to visualize this. All right. So here's the lateral, this foot right here in A. Okay. So in A and B, this is the fibula. Again, fibula representing the lateral aspect of the lower leg, and tibia representing the medial aspect. So this is a lateral swing, lateral roll with a medial glide. This is a medial swing and a medial roll with a lateral glide. So again, lateral swing and roll in vision A. So in the picture A, you get a lateral swing, lateral roll with a medial glide. In picture B, you get a medial swing and a medial roll of the calcaneus with a lateral glide. Is this open chain or closed chain? It's open chain, because remember we said in open chain, osteokinematic motion and orthokinematic motion are going to be in the opposite direction. So if this was closed chain and I had a medial swing and roll, what would my glide be if it was closed chain? Medial, okay? If I had a lateral swing and roll, what would my glide be if it was closed chain? Lateral, there we go. Now moving on to our inner metatarsal joints. Okay. So we have convex, which the convex surface is more on the medial aspect of our metatarsals, and we have the concave surface being more lateral on our metatarsals. But all in all, we have concave moving on convex. So when we have concave moving on convex, our osteokinematic motion and orthokinematic motion is going to be in the same direction. So in regards to our intermetatarsal joints, the OK motion is considered to be none because they're not moving in your cardinal planes. That's why. So they're not considered to be flexing, extending, abducting, or adducting, or internally or externally rotating, based on the literature. However, they tend to fan and fold. So with fanning, there's a posterior glide, and with folding, there's a anterior glide. So what we say was fanning. So fanning is when they're spreading apart. So when they're going into extension, our metatarsals tend to spread apart and separate. When we go into flexion, they tend to fold, which with flexion, anterior glide is occurring. With fanning, extension, or opening up, a posterior glide tends to occur. So, and this is a diagram, so y'all can go back and look at this and visualize the intermetatarsal articulations. All right, metatarsal phalangeal joints. So this is why metatarsals articulate with the phalanx. So we talked about the head of the metatarsals articulating with the base of the phalanx, right? So we have, again, concave moving on convex. So the osteokinematic motion is going to be in the same direction. So with flexion of the metacarpal, flexion of the metatarsal, you have an anterior swing and roll with an anterior glide. And with extension of the metacarpal, you're going to have a posterior swing and roll with a posterior glide. So the osteokinematic motion, orthokinematic motion occurring in the same direction. So here we go, similar to the fingers. So similar to the metacarpals, on the metacarpal phalangeal joints. And so now we're just talking about metatarsal phalangeal joints. Again, remember I told you the base of the phalanx is going to be moving on the head of the metatarsal, the convex head of the metatarsal, and the concave base of the phalanx is what's going to be moving on wet. Now here we talk about open chain position. So with flexion, we get an anterior roll, anterior slide. So osteokinematic motion, orthokinematic motion in the same direction. What else can be interchanged with flexion? With plantar. Okay. Or ventral. Extension can be interchanged with dorsal or posterior. So we got to know our interchangeable terminology. Okay. All right. Interphalangeal joints of the toes. We have our convex proximal phalanges and our concave distal phalanges. Again, the concave distal phalanges are going to be moving on the convex proximal phalanges. The orthokinematic motion is going to be occurring in the same direction. So again, the same thing as your metatarsal phalangeal joints. So same as your metatarsal phalangeal joints. With flexion, you get an anterior swing and roll with an anterior glide. And then with extension, you get a posterior swing and roll with a posterior glide. Again, at the foot, flexion can be interchanged with what? A plantar glide. Plantar, this is at the foot. Now at the hand, it could be palmar, be interchanged with palmar glide or palmar swing and roll or palmar glide. But at the foot, it can be interchanged with plantar. All right. So I can say plantar swing and roll with a plantar glide. Or I can say, what's another one that can be used? Sometimes ventral, when, depending on the anatomy and orientation, anatomical position, sometimes ventral can be a term that can be used for anterior. Posterior swing, posterior. So at the foot, posterior could be interchanged with what? Dorsal. Dorsal or dorsal glide. All right, this is, some of you all can go back and view this. We've already talked about this. This is a person making a fist. And so when you make a fist, we got swings and rolls, palmar swings and rolls at the metacarpal, not metacarpal, well, this is the hand, so it is metacarpal phalangeal, your interphalangeals, and your proximal interphalangeals, your distal interphalangeals. So all of those are gonna be anterior swing and roll. So that would be the same at the foot with flexion, anterior swing and rolls. Your ankle foot joint average adult range of motion values was with dorsiflexion, as I indicated earlier, 0 to 20 degrees, plantar flexion, 0 to 50 degrees. And when we're talking about inversion and eversion, now this right here, this is can be tricky. So here, go double check, fact check Norkin and White. Inversion and eversion. 35 degrees of inversion and 15 degrees of inversion typically refer to inversion and eversion at the talocrural joint. Typically at the subtalar joint, you don't get that much. So go check Norkin and White. So Norkin and White, I think it's gonna have inversion and eversion at the talocrural joint, and then they're gonna come back and have inversion and eversion at the subtalar joint. You notice it's gonna be much less at the subtalar joint. So this is referring to talocrural joint. All right, here we go. Subtalar joint. So subtalar joint, average adult range of motion, typically inversion and eversion is 5 degrees. But when you passively invert, when you passively perform inversion and eversion, which one do you think you're gonna get more with? Inversion. So typically you're going to get more range of motion with passive range of motion inversion. And typically you're going to get double the amount of inversion than you would get with eversion when you passively assess those. Okay? But this is for active range of motion. All right. Ankle foot muscle actions. Again, this is foundational content. You gotta know this foundational content. So for plantar flexion, you have tibialis posterior. But what else does the tibialis posterior also do? It also does what? Inversion. There you go. You gotta know that. So it also does inversion. So to stretch that muscle, you want to dorsiflex and evert. You'll be learning that in clinical orthopedics, how to effectively stretch that muscle and mobilize that muscle. But you gotta know the muscle action to be able to do that. Gastrocnemius soleus complex does plantar flexion. Peroneus longus and brevis plantar flexion, but they also do what? What do you say? Good, eversion. Plantaris and also flexor-hallucis. Then with your dorsiflexors, you have tibialis anterior, which also does what? Tibialis posterior and tibialis anterior both do inversion. Which one do you think is a more powerful inverter? It's posterior, but you want to know why it's posterior. You know why it's posterior? 4/5 of inversion, 4/5 of the muscle fibers for inversion come from the posterior tibialis muscle, and 1/5 of the muscle fibers for inversion come from anterior tibialis muscle. All right, ankle foot muscle actions are inversion, tibialis posterior and anterior. We just discussed that, right? We know why tibialis posterior contributes more so to inversion than the anterior tibialis. All right, inversion, the flexor digitorum longus, also contributes to inversion at the ankle. Eversion, we talked about it, peroneus longus, brevis, and tertius, performing eversion. Now, knowing these muscle actions are very important because the positioning of one's foot, rear foot, ankle, we can get a glimpse into what neuromuscular inefficiencies that the person may have, right? And so if we know how the muscles are supposed to be pulling, we know the forces that the muscles are supposed to be providing to a joint or to a structure, we can figure out what these muscle imbalances may exist, okay? So for a person, say a person who's excessively pronated, all right? Excessively everted, okay? And we know that the posterior tibialis is an inverter. So now we know, okay, this posterior tibialis may be weak. We need to look at that, okay? It could be stretched. It could be excessively elongated. Most likely it is, and the tendon is if this person is constantly pronated. So now we know, oh man, we need to strengthen this person's posterior tibialis muscle because they've fallen in too much pronation. The muscle is probably lax and weak. Ankle foot muscle actions, these are just diagrams again, showing the muscles and how the forces of those muscles. Okay. Toe joint muscle action. So these are muscles that go all the way and act at the toe joint. Flexor digitorum longus and brevis, flexing the toes, flexor hallucis longus and brevis, flexing the great toe, the hallux. Flexor digiti minimi brevis, flexing the fifth digit, or fifth toe, quadratus plantae, the lumbricals. Then we have extension, performing extension at the toes, extensor digitorum longus and brevis, extensor hallucis longus and brevis, and also your lumbricals as well. Colorful diagram. Your toe muscle actions for abduction, abductor hallucis, abductor digiti minimi, dorsal interosseous. Adduction, adductor hallucis, plantar interosseous. We know how to manual muscle test those, so we're gonna know how to do muscle selective tension testing of those. All right. Another diagram for you all to study. And now we arrive to some of our special tests at the ankle joint with ligamentous instability. The tests that fall under those are your anterior joint test, your lateral rotation stress test, Taylor tip test. We're going to be looking at the structures that they assess. Miscellaneous tests are your Holman sign, Thompson's test, tibial torsion test, true leg length discrepancy test, leg length discrepancy test. We'll be looking at those. All right. What questions do you have?